so I'm just conscious that we need to try and keep the pace going. So without further ado, we have apologies for absence from Russell, who's on his holiday. Sure, thinking of us while he's having his holiday, and I'm deputising for him. Graham Nuttall, Phil Gilbert, Rosemary Hyde, and Sarah Moffat, for whom Ellie Ward is deputising. And Sarah, you had a couple of others you mentioned earlier on.
Thank you. So we've also got Kathy Wagstaff and then Roger Weddell, who is our new staff governor for clinical support.
Okay, super. Welcome to our new governors. So we have a declaration of qualification for office. Sorry, let me get that out in English again. Sorry, declarations of qualification for office and any declarations of interest. Oh, I've read that now properly. No declarations of interest. Okay, super. Is everybody happy that the minutes of the meeting held on the 12th of May are a fair and accurate reflection of the discussions that took place? Very good. Sarah, I think you had one amendment you picked out, I think.
Yeah, Yasmin Becker has informed us that she was actually in attendance, so we need to reflect that on the final version, please.
Super. Okay. So, moving on. There are no matters of minutes for action or matters arising, so that moves us into our assurance agenda and Glenn for an update on COVID resurgence and winter planning.
Yeah, okay. So there's a little list of other things that Governor's asked for a bit of an update on, which I'll do at some point as well. Okay. So from a COVID and winter perspective, so firstly, COVID, the numbers of COVID cases in hospital has continued to fall, which is good. And I'll look at my board and I'll give you the scores on the door. So I mean, it's always interesting to look at it across the group. Actually, there's 7 cases in beds in our trust. There's 5 in George Eliot, 4 at Wye Valley, 1 in Coventry Watch Partnership Trust. There's actually 70 at University Hospitals Coventry Watch. So there's quite a high number still in Coventry. I'll probably just caveat all of that with 2 weeks ago now, we have changed the testing protocol, so which is a national change. And prior to that change, we tested every single patient on admission to hospital. The new protocol is you test just those symptomatic patients. So that will automatically lead to a situation where quite a large number of patients that we were previously testing who were not admitted for COVID, but we just happened to find that they had COVID during their admission, will probably not be in the numbers unless they start to get symptomatic, when of course we will test. So, but I suppose the summary of that is that we are certainly seeing less pressure from a kind of isolation perspective, which is helping us to manage beds. Helpfully, yesterday, actually, in the board workshop session, we had an update on the long COVID clinic. And that kind of reminded me that whilst the pressure from an acute perspective on beds from a COVID perspective is easing, long COVID is not easing. And there are obviously a number of patients who are taking up what is an excellent service, actually, from what we looked at yesterday. A lot of patients taking up that long COVID service, which is supporting people to manage and to get back to normality. I would strongly encourage any governors who weren't at the meeting yesterday to just take a little look at the video recording of the meeting, not the entire meeting, because I wouldn't inflict that on you, but just certainly the first part of it, where Harkamel gave a really good oversight of our plans for this winter. And then in my chief exec's report, which is in the papers as well, as is her slide set, I talked about the national winter plan. So if I first talk about national and then local, the national position is that on the 12th of August, we had a national winter plan published, which is the earliest on record. as far as I'm concerned, so it must be the earliest ever. That helpfully set out some of the things that we're going to do across the NHS, including investment in what they refer to as 7,000 beds or bed equivalents. And just to be clear about what a bed equivalent is, it's doing something in the patient pathway which takes that capacity requirement away. Actually, I much prefer bed equivalents, particularly if these are solutions that allow patients to be managed at home. So things like virtual wards, for example, admission avoidance schemes, all of which avoid taking people unnecessarily into hospital. And hospitals are great places to be when you're acutely unwell, but not always the best place to be when you're not. So we've got our local share of those bed equivalents as well. So those plans are going in across the NHS. There are serious concerns about this winter. I think it's fair to say, and I often find myself saying this is going to be the worst winter that we've had from an NHS perspective, and I'm usually right, and I'm going to say it again this year. Combination of factors. Obviously, we have an unknown COVID situation. One hopes that it continues to be an increasingly mild strain of COVID, and therefore it doesn't have the impact that it's had certainly in the last couple of years. But because of 2 winters of suppression of respiratory illness via lockdown, we can expect to see other respiratory viruses circulating in all age groups, including young people, children, all of which will add to the demand picture. Other factors, well, we're at 96 to 98% occupancy. We're at winter levels of occupancy already, and we're at the better end of the spectrum on this locally. So what's it going to be like as we get into the winter? We have obviously concern about fuel poverty and poverty over this winter, and the impact that could have, particularly on frail older people who if they don't put the heating on or don't feed themselves properly, the implications that could have for admissions to hospital. We've got a big crisis in domiciliary care capacity in social care. We also have the prospect of industrial action. The nurses in Scotland have voted for industrial action. The view is that nurses in England will vote for industrial action. However, many of them need their pay. So I'm not sure what that industrial action will look like, but obviously we've got to brace ourselves for that also. So we're preparing ourselves for a lot of pressure. And so my view is that all that stuff in the national plan is great, but it's not enough. So there's been some national discussions about what more we can do, which I've been involved in. But also locally, we've been dusting off our plan and having a look at our local modelling about what we need to do. And the modelling that we've produced estimates that we need to find the equivalent of 73 beds extra in the trust in order to get through this winter. And Harcomel and team have got a really good plan for most of that. But it still falls short at the moment, and so we're still doing some work on a number of solutions. And again, our plans are not about building more beds. I'd rather we didn't provide more beds. I'd rather we did more outpatient prescribing of antibiotic therapy. I'd rather we did more admission avoidance. I'd rather we slickened our discharge processes so that people are out of hospital as soon as they are ready. On that point, on the discharge point, we had a visit from Hugh Pym and BBC film crew on Monday. They spent the whole day with the trust. They joined the morning bed meeting, the lunchtime bed meeting, the evening bed meeting, went out and looked at some of our frailty services. So that should be quite an interesting insight into the way the hospital works, the way the system works, and what the pressures are around discharge. That might go out today, although it will go out at some point, but it will be a national piece. And I think it's fair to say we are seen as doing a lot of things really well. Gina, I should have mentioned the fire service feature in that as well, in terms of getting people home. which obviously is something we're really proud of as well. We also had a visit from Amanda Pritchard, the Chief Executive of the NHS, a couple of weeks ago, and she had a look around various things, including the frailty service. And they have been pioneering a model which takes patients from the ambulance stack, the queue, waiting to have an ambulance dispatched, that are suitable to over 75 patients who are more likely to be frailty because of the presenting issue, and then dispatches a special ambulance with a paramedic and frailty nurse on, and that special ambulance has the ability to talk directly to the frailty team at Warwick Hospital. And that work has demonstrated a 50% reduction in the number of frail older people that are then transferred into hospital because we put other solutions in place. And those patients who are conveyed to hospital go straight to our frailty unit rather than having to wait at the front door in A&E. So it's a really good model, actually. And Amanda spoke to this national forum and said, I quote, "I've seen the future is in South Warwickshire." So that was nice to hear. But we need lots more ideas like that, to be frank, to get through this winter. So and the teams are working on those. And I think one of the other things that she said about what she experienced here is lots of people with lots of ideas that we are encouraging to implement and evaluate and then keep the good ones. So there's a lot of work going on that. We've got our own versions of virtual wards. Probably just, I won't go on too much on this one because I could do a whole hour on winter, but the one other thing that I think we need to spend particular time on is the relationship with care homes across the system. We've developed this technology assistance, which is called Docabo, which in effect can turn every nursing home bed or care home bed into a virtual ward, because it's a portal which keeps an electronic patient record and then links into primary care or secondary care. So that's been great, and we're going to use that we've rolled it out across the whole of North Warwickshire, parts of South Warwickshire. We get the whole of South Warwickshire on that as soon as possible. And then things like that are really going to help us to ideally look at a situation where our bed stock not only includes the beds in the hospital and the community hospitals, but also all of the care homes. And we keep people in situ, we get teams in, support them and provide better care as a consequence. So that's what we're setting about doing. But in all, we will still have our moments this winter. And one of the things that will also contribute to that, and I know governors have raised some concern about this, is that because we generally turn ambulances around quite quickly, we get what's called intelligent conveyancing, which is ambulances from other systems that don't want to wait for a long time outside Worcester Acute or University Hospitals Birmingham come to us, which is great for those patients. It means that those crews can release the patient quickly and get back to the next patient in the community. One of my worries about it, though, is that those patients, particularly if they're frail older patients, they generally are harder to discharge because we're discharging into other systems, not our own familiar system, not our discharge to assess capacity, not our district nursing capacity. So I think we just need to watch carefully whether speeding up the ambulance actually really helps with overall capacity in the NHS because of those delays that come from it. That's probably it from a winter perspective, Simon. Shall I pause there and then maybe I'll just go briefly through some of the other points that governors have asked me to talk about?
Oh, okay. So do you want to do that now, Glenn, or do you want me to?
Yeah, it's just, are there any questions on that? And then I'll move on. But no hands.
Any questions for Glenn?
That's good then. But oh yeah, there's one.
One. So Mary.
Thank you. You've mentioned that we're not COVID testing patients and if they have symptoms. Are we monitoring the impact of that on any sort of COVID occurring on the wards or with our staff, because people still can be infected even if they've no symptoms. So are we opening up to the risk to other patients and staff?
Yes, so this is not a local decision, this is a national approach, but what we are doing is obviously if they become symptomatic, we test. We do lateral flow test and then followed by a PCR test to confirm it. So that would tell us if this approach is leading to more incidents. We also, though, still will test every patient on discharge to a care home. So we will also get a kind of backdoor position on whether we've got COVID incidents going up. I think, though, Mary, whilst I share the concern, the problem that this was creating for across the NHS was obviously cohorting a number of patients who were otherwise pretty well, actually, which led to a situation where lots of beds were blocked and wards were blocked and causing more risk at the front door of the hospital, with ambulances queuing, etc. So it was a risk balance judgment.
Yeah. Are we still wearing face masks?
Yes, in clinical areas. Yeah.
In clinical areas. Thank you.
Okay, thank you, Mary. Sue.
Really, Glenn, I just wanted to say, and you probably know I am a member of the RCN and I am a steward for the RCN. And I just wanted to say that the vote that starts in September, it's something that we've been pushed into with 10, 12 years of sub-inflation wages rises. But actually going around talking to staff, and I have to be, and I will be, and encouraging them to vote. How they vote is their choice. But I was quite surprised, really, that the number of people who had said to me, absolutely, we're going to say yes. And they didn't say not because of the wages. Yes, they are worried about the wages, but actually they're far more worried about being able to deliver safe care to patients because there aren't any nurses. And it isn't anything to do with the trust, it's a national issue.
Yeah, well said, Sue. I'm certainly not going to comment on it. Obviously, as an NHS leader, I'm not going to get into the politics of it. But obviously, we've got to try and respond to it. But
yes,
I completely understand your point.
And we would, the RCN obviously would be working very closely with the trust and making sure we deliver safe care. And I wouldn't expect you to, but I just want you to know it was nothing to do with the trust.
Sue, thank you very much. Thank you. Okay, Glenn, you have a couple of other points.
Yeah, I won't take too long because it's a challenging agenda for you, Chairman. So I shall march through a couple more things. So there was a request for an update on research. Those of you who saw my board report yesterday will have noted that our name change has gone through. So South Warwickshire University NHS Foundation Trust. We've done that at no cost, well, minimal cost. It may have cost a few pennies to update a few bits and pieces that we needed to, but it's been done, discreetly is the best way to put it. But linked to that, we've approved a research strategy at board level. We obviously have the new non-exec, which you're all familiar with, and he's been a great addition to the team. David Al-Dalami, our clinical lead on this, is working really closely with Simon Brake, who's the managerial lead and linked as a joint post with the university. We're putting in some more support posts to encourage research in all disciplines. And also there's a link from this into the digital hub, because quite a bit of our research is around technology solutions as well. So that we'll keep providing periodic updates. Indeed, it's covered in the assurance report later also. Swift Clinical Services, we took an update in the confidential section of board yesterday. The transfer of IT services into Innovate has gone well. There's been a staff poll in terms of their feelings about the way that's been managed, which is giving some positive feedback. The Lillington project, which I'll talk about in a moment, is something that the company are working on quite heavily at the moment also. Work on host provider linked to the integrated care systems. I'll try and pull those two things together. So the integrated care system went live across the NHS, all ICSs from July. I am a member of the Integrated Care Board representing Swift and George Eliot, and we're finding our feet with that. For me, what I would like us to be doing in the Integrated Care Board is joining up the services with other partners, particularly our local authority colleagues, looking at prevention, looking at the wider determinants of health. I don't want this to become another layer of performance management, because we've got enough of that going on. And I think the expectation on organisations like ours is that we're well led and we're well governed, and that we'll deliver on the things that are asked of us. But we at Swift will be taking on responsibility as the kind of lead provider for the Warwickshire patch, working with colleagues at George Eliot and UHCW for rugby, to deliver to our local communities, and I hope that will evolve a bit more into the future. The Lillington project went through board yesterday. It's a bit like the Shipston project in that it's bringing primary care and our community services into one facility in Lillington. The Covington Road GP practice will be part of that, and bringing in some other kind of wider community support. The Lillington patch is the most deprived part of South Warwickshire, so it's great to be able to invest in that local capacity, and the business case was approved subject to a couple of caveats by board yesterday. And then there was a request for Force Court update, which is the automated cyber security system. We have invested in that through the Innovate arm's length company, and what that does is maps our IT assets, and there's thousands of them across the organisation, and protects those assets from cyber security as best we can. Although I have to say that all the cyber updates I get are not about how you avoid it, it's about how you limit it and how you cope with it when you get it. And you may have noticed that there was that one of the providers of an IT service, so an independent sector provider, had a serious cyber attack recently that affected a lot of mental health services and the 111 service, and that's had a direct impact on our local mental health service, and that's been a really hard one to manage for them, and it's really kind of brought home to us the importance of business continuity planning, because, as I say, I think these things are almost inevitable now because of the sophistication of those cyber attacks. That's probably it on that one, and then I'll come back and do the quarterly status report in a moment, if that's okay, Simon.
Lovely, thank you very much, Glenn. Has anybody got any observations or questions for Glenn before we move on to the Ockenden update? Okay, lovely. So if we move on to item 5.1.2, which is the verbal update on Ockenden. So Lynn, if you're there.
Yeah, hi everybody. So I'm going to do a verbal update for you today. So I do hope I can provide you with enough information and a high degree of assurance that maternity services at Swift are safe, and that I just wanted to reiterate the point that we do continuously strive to improve our care and our safety compliance in all areas, not just Ockenden. So just an overview of what we've been focusing on in maternity in the last few months. So obviously our continued hard work against the Ockenden report and compliance, but also our work on the maternity and neonatal safety improvement programme, where we are running several improvement projects. And also, as always, our focus is always on our staff and wellbeing and retention. I did just want to take the opportunity to share some really good news with you all. We've been awarded the UNICEF Level 3 award for our infant feeding services. We've continually worked on this throughout the pandemic and have been commended by UNICEF for gaining this award in quite challenging times in maternity and during the pandemic. So as you're all aware, the final Ockenden report was released at the end of March of this year. And as a team, including obstetricians, neonatologists, anaesthetics, and of course midwifery staff, we've pulled together aspects from the original report that was released in December of last year, the final report released in March, and the report from our Ockenden Insight visit that we had in April of this year. And we've developed a really detailed action plan. The team meet monthly and we ensure to drive each action forward in a timely manner. So work continues against all 15 immediate and essential actions. Each of these 15 actions have multiple actions within them, and often we at our meeting add new actions to them. We are on track to complete 5 full actions by the end of September, and we are on track to complete a further 5 actions by the start of next year. Funding for Ockenden specific progress has been awarded to us via the local maternity and neonatal system. That will really help support our progress. A few areas just to highlight that we are still working on includes the full rollout of personalised care and support plans for all our women, the full implementation of Saving Babies' Lives version 2, a robust audit process within maternity, and our compliance with the National Bereavement Pathway. We're making significant progress completing all of our actions and always identify the actions of the highest priority for women's safety. And we also keep track of our compliance really closely. I just wanted to go back to the Saving Babies' Lives compliance, because that is a significant part of Ockenden, and we have made a significant improvement, to reassure you, in our compliance, and NHSE have been working very closely with us on this and have commended us for our work. So while we are not fully compliant with that at the moment, we have made really good forward steps, and we hope to be compliant with Saving Babies' Lives very early next year. And I would be happy to take any questions.
Okay, Lynn, thank you very much. So any questions for Lynn? Mike Flaxman. Mike.
Thanks. I noticed something about the reduction in births in the midwife-led birthing unit, and I wondered if that was a staffing issue or whether we were having more complicated births that needed to be dealt with elsewhere.
Yeah, oh, thanks, Mike. It's a combination. So we have been hit like everywhere else with the pandemic. So staff sickness has impacted on our staffing of the birth centre. What we often have to do when there is high levels of sickness is pool our resources. Intrapartum care, we have to sustain safety. We have to be able to provide one-to-one care. So that has had an impact. You'll probably see in the last few months it's fluctuated quite a lot. So we've got back to quite a comfortable number of births, but we are striving to increase those births month on month. We do have an increase in complexity as well. We've seen since 2018 an increase in our age of our mothers, an increased BMI of our mothers, so that does add to complexity as well.
Yeah, your birthing pools are active then?
They are, very.
Good, thanks.
Okay. Thank you, Mike. So Jean.
I just want to congratulate Linda on the award. I know how much hard work and detail from all of the staff go into that. And I also want to give assurance because Linda brought the full report to the Clinical Governance Committee, which I'm a member of, and assurance was given at the report. They obviously really looked into it and asked lots of questions, but at the end, everybody was assured. And I just want to say, on a personal basis, my great-granddaughter was found to have no heartbeat and had a perinatal death, and then was induced. And I just want to say that the support and help that you gave her and her husband and the whole family was just amazing and wonderful, and took account of the whole situation. You're not just dealing with a death. And I also asked at Clinical Governance if you also looked after your doctors and consultants, because they also must find it really hard when you lose a baby. And you assured us that yes, that you have team meetings where this is discussed, and so that people feel able to share their feelings. So thank you.
Thanks, Jean.
Jean, thank you for making that point. That must have been very hard to make for you. So thank you very much. So if we move on to Joe Barker.
What sort of impact are you finding from our struggle with health visitors? Are you feeling that midwives are managing to bridge the gap or having to fill the gaps? Any advice you can give us on finding some health visitors lurking under any stone would be gratefully received.
Yeah, I have to say we've got very good relationships with our house visitors in South Warwickshire, and we, you know, if there is a shortage of any house visiting, then we try our best to continue the care where, you know, where possible and where appropriate. As much as we lose a lot of midwives to house visiting, and obviously we're short in every area of healthcare. So we've had some really successful house visitors come from Warwick, but also I'm very keen to keep our midwives as well. So yeah.
Thank you.
Okay, thank you, Jo. So we have 3 more questions and then we'll move on. Otherwise, we're going to get well behind time. So, Sharon.
I would just like to echo Jean's congratulations on your breastfeeding award. And I don't have a question, but I would just like to say that it's been a pleasure working with Julia Smith to recruit volunteers for the breastfeeding support programme. We already do it in the community from the north to the south of Warwickshire. And now I understand we have 4 volunteers working with Julia to assist new mums or parents with breastfeeding. So thank you.
Okay, well said. Thank you, Sharon. And Sue, finally.
Right, I was only going to say to Linda, thank you very much for your comments about health visiting, being a South Warwickshire health visitor. And our relationship with our midwives, particularly the community ones, is grand. I mean, I work alongside Lindsay Collins, couldn't be better. The information I get is superb.
Brilliant.
Super. Thank you, Sue. And Lynn, thanks very much for your presentation and well done.
Thank you, everybody.
Okay, so Glenn, I think we're back to you now on operational assurance and the quarterly status update for Q1.
Okay, thank you, Chair. So for those governors who maybe aren't familiar with this because you knew that the what we do at Council of Governors is provide a quarterly update on progress against the objectives that we jointly agreed for this year, so that come out of the roundtable events that we have in the autumn and spring. So these are the organisational objectives, and the report that's in front of you just goes through updates from the relevant executive leads and identifies what we're trying to achieve with that objective and where we are with progress. I'm not going to go through the whole report. I'm just going to pull out a number of areas that are rated amber, and there's not huge signs to the red, amber, green rating. It's just an indication of where we think we are with these things. Obviously, we're in Q1. We're reporting on Q1 of the year, so we'd expect more ambers at this stage. So just 1 or 2 bits and pieces. Just firstly on our net carbon zero aspiration, we are pulling together a bid with some specialist advisors for what's called the Salix Fund, which is a fund that exists, which is an interest-free loan arrangement where we can invest in things that reduce our carbon footprint. So we will be making a bid towards that, which will help us towards net carbon zero. And obviously we're planning that into all of our new estates investments. There's also within there an update on the elective hub bid. We are planning to replace, the main part of this is to replace our day surgery unit linked to the estate strategy that you'll have seen both at this forum and at board. And that's coming together reasonably well at the moment, including within it the ability to create a new front door on the site, because we haven't got a front door, we've got multiple doors and more and better staff facilities. So that is coming together. Our electronic patient record business case, we went through that in a kind of draft form yesterday at board, and it will come back to our main board meeting next month, hopefully for approval, and that would then signal the implementation of an electronic patient record at South Warwickshire and George Eliot, which is also a common system to the one that's currently being implemented at University Hospitals Coventry and Warwickshire. So the integration is really key there. There's an update on the NHS app and the link to our patient portal, which would be great. So for everyone who has the NHS app, they'll be able to get straight into our portal to look at their records, but also to amend appointments. And then there's an update on robotic surgery. This is quite a strategically important one, where surgery of the future will be assisted by robots. It won't be done by robots in isolation. But in order to train surgeons of the future, we want to have that technology in the hospital. And it will improve outcomes as well with the technology we're looking at. So we're pulling together a business proposition on that. I think it's probably fair to say there are other parts of the NHS that think that district general hospitals shouldn't have robotics, and therefore we will have to make a case for the DGH, because this is quite an important strategic thing for us. As I say, if that's the future, then we want the best surgeons here, so we need to make sure that we're in that game. So we will be manoeuvring ourselves into that through some shark infested water. Okay, that's all I wanted to go through. I'm happy to take any questions.
Thank you, Glenn. Any questions or observations for Glenn?
Hello, sorry I didn't raise my hand. Is it all right to ask a question, Simon?
Yes, Callie, go ahead. Yes.
Yeah. I just wonder what's the leveling up report has been presented. You're doing a lot of work on leveling up. Has been presented to board this report, because obviously it's listed in the yeah.
Yes, it has.
That's just wanted to find out a bit more about the leveling up report. That's all.
Okay.
We could bring that here, Simon, if that would be helpful. So I'm trying to remember when it has gone to board, but we can certainly make it available to the Council of Governors. It's a report that's very much focused on place, so not just us, but it's a really compelling update on where we are, but also some of the things that we've got in train to assist with levelling up. So it's maybe something we could talk about in a future meeting.
Glenn, I think it's a very good idea, because it's a strong focus on what we're doing, and you'll find it valuable to listen to.
Okay, thank you.
Okay, Mike.
Yeah,
Mike.
just quickly on that exact topic. I've got a meeting on Tuesday next week with Anna Coyle about levelling up and cost of living crisis.
Right.
So stuff is happening, conversations are happening.
Super. Thank you for telling us, Mike. That's great. And Mary, finally.
Yeah, very quickly, I'll take that to the next General Purposes Committee and we'll put it on the agenda for the next council.
Excellent. Well done, Mary. Thank you very much. So, and thank you, Glenn. So, conscious of time and keeping the pace up, but Ellie, patient experience assurance report, which is very important. So, thank you very much.
Thank you, Chair. Conscious of time, then I'll just briefly say that our formal complaints remain reassuringly at a very similar level to pre-pandemic, with no particular areas standing out as having high levels of complaints. The eagle-eyed amongst you will have noticed in the report that PALS contacts have been climbing quite significantly, but it's important to recognise that actually what we're now seeing is more of a normal level of contacts that we had before the pandemic. And a lot of the contacts we get with PALS aren't actually around complaints. It's a lot of signposting and information giving, and that's what they're there for. So I'm pleased to see they're receiving the calls. I also happen to know the last couple of months that's come down slightly and is about where we would expect it to be. We continue to work on engaging with patients and carers and getting feedback. We are implementing more text messaging type responses, and that's worked particularly well for us in areas like A&E, where we've gone from receiving very low response rates, and every month we're seeing that go up and up, and that's continued to climb, and that's resulted in getting a higher recommended score. So although you can't see that in this quarterly report, the next quarterly report, which I've seen, you will see that score is going upwards, and we're going to see if we can use that in other areas, but we will continue paper forms for those, so we don't make sure, so make sure it's a blended approach so nobody is left out. So other than that, I'm happy to take any questions.
Okay, thank you. Glenn, just for the record, I think it's worth saying this. We consider this a very important part of how we understand what's going on in the hospital and how we keep our services focused and sharp.
Yeah, absolutely. Both patient surveys and staff surveys are really driving what we plan to do.
Thank you. Excellent. So, Jean, you had your hand up first.
Yes, just to give assurance about safer discharge, and something that we have in the recent past had complaints about with TTOs, etc. And I just want to commend you for the trial you've got on at the moment in terms of a pharmacist technician on the ward. And that has considerably reduced, and that you're thinking of moving to include another ward so that the actual numbers that are generated actually have a bit of statistical background to them. And if, seeing as we're all together, if we make a plea to Glenn, can you give enough money so that we have them on all the wards where there's issues of this type? Because if we could have this widespread, actually would make quite a significant difference. So sorry for that plea while we're on, but congratulations, Ellie.
Thank you, Jean. And you've made a really good point there, actually. It isn't just about the feedback we receive, it's about the fact we do stuff with it. So we look for themes and issues, and that was one we identified and picked up and acted on to make things better. So thank you.
Thank you, Ellie. Well said. Roger, and then Mary, and then we'll move on.
Thank you. Noticed in the complaints that Beaumont ward seemed to have a particular problem, and looking at the complaints per 1,000 bed days, they are very much an outstanding.
They were outstanding, not in a good way, Roger. That's
no, precisely.
Yeah.
Are there adequate measures to deal with whatever theme that that provoked?
A very specific person-centered theme, which is no longer an issue in that area. And actually, I've seen the subsequent reports for the next 3 months, and they're no longer an outlier. That
excellent, excellent.
The one-off spike.
Yeah, good.
Something quite specific.
A good example of timely action to get things right. So thank you.
Thank
you, Roger. Thank you, Ellie. And finally, Mary.
I was going to raise the Beaumont question as well, as Roger beat me to it. But my other comment follows on really from what Jean was saying, and I don't know whether it's come back to you yet, Glenn. But the question that I raised yesterday about the apparent reduction in pharmacy establishments on the staffing report. And I would hope that's not happening. There's an explanation for it, because as Jean explained, we need more pharmacy staff, not less. I don't know.
Yeah, I've not had the answer back, Mary, but absolutely on the case on that one. As I said in the board meeting, my immediate response is that we've not approved any reduction in their establishment, so we just need to check that whether it's just a reporting thing. It's hard to recruit, as you acknowledge, but we're certainly trying to continue to.
Yeah, they did have a large vacancy factor which they were recruiting into, but I'm not aware of an establishment reduction.
Okay, Ellie, thank you very much for your presentation. So moving on, clinical governance assurance report. Dave Spraggett.
David's not joined us, Simon, so I don't know if you just want to take it as read and we'll minute questions and feed them back to David.
Sarah, thank you very much. So
thank you.
We will follow Sarah's advice. So we'll take the report as read. And are there any questions around David's report? Okay. Oh, we have one. Mary?
Just so that the questions actually in the public agenda was the question that we raised about the HSMR being elevated, and we did get an explanation of that, but I think it has been noted by the governors and the question's been asked and we've been given assurance.
Okay, thank you, Mary. Glenn, you wanted to come back on that, I guess.
Yeah, so Chief Medical Officer addressed this yesterday in the public board meeting. It's one that we're keeping a close eye on. We've seen it in the other two trusts in the group. What we need to just understand is whether that's about COVID mortality not necessarily being in the numbers, but also one thing we've noticed is that our palliative care coding has slipped, and palliative care coding adds to the complexity of cases, and sometimes it may be that we're not getting the right complexity alongside our standardisation of our mortality. So we will report back in future months as to where that takes us. We're still within the expected limits, and not an outlier, I think is the main point on that one.
Indeed. Glenn, thank you very much. Thank you, Mary.
Can I come back, Simon? There's a one line somewhere says radiology and pathology will be subject to a recovery plan. And given the concerns we've got about some of these services, do we have a timescale for when that recovery plan will be started to put in place?
Okay, I think, Glenn, are you in a position to answer that, or do we need to bring that back?
Yeah, I wasn't at that meeting, but I think the recovery of our turnaround times is probably one of the issues that we just need to make sure is there. I mean, actually, our radiology turnaround times are some of the best, well, are the best in the NHS, but we've seen a bit of a dip in ours. But I'm not sure of the timeline for that, but we can come back on that one.
Thank you.
Okay, thank you, Mary. Thank you, Glenn. So if we press on and move to Kim then for her finance assurance report. Kim.
Thank you, Chair. Hello everybody, nice to see you all. Very conscious that this is probably the first report in respect to the new financial year. So if I just take a couple of minutes to remind people around the financial regime that is in operation for this new year. Essentially, majority of the funding that we receive is on a block allocation basis. It's been devolved down to our system level and then divided up between the provider organisations within the system. There's an element as well that is related to the Elective Recovery Fund, which is around some additional funding that we could achieve if we achieve 104% above our valued activity in comparison to the 2019-20 year. But essentially it's largely a block contract. You'll be aware there's been a significant investment in the NHS over the last couple of years during COVID, and this year effectively the Treasury are asking organisations to try and get back to the level of spend back in 2019-20. So it's proved quite challenging for the system and the organisations to live within that plan. Having said that, we originally had set a break-even plan for the organisation, and but subsequently to signing that off at board at the beginning of the year, we were notified that there was further inflationary funding that was going to be given to organisation. And as a subsequent result, the Trust were asked to deliver a £3 million surplus plan for the year. The report that's been presented to Council of Governors shows the Month 2 position, which shows a variance from plan of just under £2.2 million deficit against that break-even plan. Since then, I reported to the board yesterday around the Month 4 position, where once we've made a recognition for some additional income in respect to our associates like Solihull, Mutual Aid and some other non-recurrent benefits, we are delivering a break-even plan against the year-to-date surplus plan that's been required. There is a large a piece of work in respect to the financial reset that we've engaged the whole organisation on, and we took through the detailed plans through with our board members through the confidential session yesterday. Challenges for the organisation is around delivery around our CPIP target, which is 10 million for this year. But the other issue is the challenge around living within our agency control totals Agency spend has been significantly increased over the last couple of years. But again, if I can give assurance really to members that we have got controls in place and mitigations in place while making sure that we maintain financial control as well as maintain safety of our patients. So we are still forecasting that we will deliver the surplus plan for the end of the financial year at this point, but we have got a series of mitigations that are in place to do so. Happy to take questions.
Okay, Kim, thank you very much. Any questions for Kim? And Mike?
Yeah, one's a comment initially. I've only been in this job for 2 days now, catching up with it a bit. My commiserations on yet another change to the financial regime, and they seem to come up with considerable frequency. And I look forward to learning more about it over the coming months as I get my nose into it. The other issue I think is on reporting to the Council of Governors, where we've only got a month 2 report, but the board had month 4 yesterday, and I think we should be at the same stage as the board, if that's all right for the future. Thanks.
Mike, Kim?
Yeah, happy to pick that up. I think it was the timing, I think, of the sending out the papers, really. So I can liaise with Sarah to ensure that we try and get much more in step in future.
Okay, well done. Thank you very much, Kim. And Roger Lloyd.
Kim, with the run rate of agency, which I know you watch like a hawk, but with that run rate, you're saying that we should be able to digest that, but at the end of the day, are NHSE going to complain and take action, or perhaps region take action against us because we are not keeping within the control total, which if we were to do so, we would not be able to deliver safe patient care?
Thank you. It's a good point, Roger. You know, there are controls that are issued nationally, and I think you know, all organisations are struggling to live within those original ceilings that were set by NHS, i.e., you know, a few years ago, because effectively they've kept the ceilings the same. I note that Glenn's put his hand up straight away, so I'm sure Glenn's got a view as well.
Okay, Glenn, thank you, Ken.
Yeah, I think first and foremost, our overall financial position will drive this more than anything else. But obviously, if we're off plan and we're above our agency cap, then I imagine there will be questions asked. Just to make it clear on those, though, they are based on the historical spend for each organisation, and because we've been historically low on agency, we have a low cap. In fact, we looked at this at the recent 3 boards meeting, and whilst we're worried about our position because it's doubled in a 2-year period, we're spending about 5% of our pay bill on agency. Elsewhere in the group, it goes up to around 15%, and most trusts are well above where we are. So we're in a good place, but it's not great. And as I said in board meeting yesterday, it's not just the money here, it is the quality associated with not having our own substantive staff. So we absolutely want to do something about it.
What? It's all right.
Okay, Glenn, thank you very much. Any more questions or observations for Kim before we move on? Okay, thank you very much. Thank you, Kim. So we move on to Richard Colley on audit assurance.
Good afternoon, everyone. Rosemary's on holiday, but it's probably timely because I've taken over as the audit chair. So thank you for appointing me early in the year, and after having about 6 months of handover on the audit chair. Just to put in context, a couple of things. I think some of the things we're talking about, controls within Kim's, with the COVID for 2 years, life was very different. and people were short-staffed coming, and all of a sudden we've changed the rules again about we need to go back to being monitoring. So what was the norm for the last 2 years was not the norm. Now we're going back to the norm 2 years ago. So controls and everything else we need to re-establish in as part of the ethos. In terms of the issues to talk about, there was some problems with the year-end audit with health and the external auditors, and we resolved those. So we were a bit behind schedule, but we've now done it. So, and we've gone and had a debrief with them. There are some internal audit processes are going well. A couple of things have changed. Things like pathway to delivering zero. That's new, so we're just starting to go through the process. We've got plans to get through there. And one of the things that did come up in the last year's audit process was the reviewing the external scanning of documents, which I think would probably be, because it was an outsourced organisation, we weren't completely on top of, but we've got proposals in place to get through all of that. So I'll take the rest of the report as read.
Richard,
unless any questions.
Super. Richard, thank you very much indeed. Are there any questions or observations for Richard? Okay, thank you very much. So we now move on to the reports from representatives on projects and groups section. And first out of the box is Mike to talk to us about Ellen Badger. So thank you for your work on Ellen Badger, Mike, and perhaps you can give us your report. You're on mute, Mike.
PC's having a slow day today. So I'll take the report as read, but there's only a couple of things really. Disappointment that the medical centre at the moment have had to step away for funding reasons, which are explained there. Trust are pressing on though. Sophie's building a plan to keep the same footprint, but just not build the opposite the medical centre bit. And the other thing is that the Trust are actively participating in a lot of the Stour Health and Wellbeing Partnership stuff. So Karen Parker's got involved and was at a meeting on Monday about the pop-up wellbeing hub. So that's getting activities going before there's a building. So finding places in town. And the next board meeting's on the 14th.
Okay, thank you very much, Mike. Are there any questions or observations for Mike? One. Other Mike.
Sorry to pop up again, but it's just a comment and an observation. NHSE having mandated steel frames for new building construction in many areas, particularly diagnostic units, are basically the cause of a lot of overspending because the steel was all coming from Ukraine. And projects are going up by between 50 and 100% above budget. And my brother is trying to deliver a new health facility in northeast London. And the budget for that's gone from 20 million to 36 in tendering. And it was one of Boris's 40 new hospitals. And they're all worrying at the Treasury as to how they're going to actually deliver them now. Quite interesting. Anyway, just a comment.
Mike, thank you very much. And Joe.
I have been invited, as some of you on here have been, by the League of Friends to be savaged in public on the 20th of September over the Ellen Badger. I intend to go. I don't intend to be completely savaged. And I wondered, I know, Glenn, you all have had an invite and I'm sure you're not coming, but I wondered whether anybody from the Trust was actually coming. The thing that seems to be really exercising them still is beds, and most locals cannot differentiate between the GPs and us. And so I'm spending a lot of my time saying, look, we've done the right thing. Swift has actually stepped up, blah, blah. And I just wondered whether anybody was actually going to come to that meeting and say, no, Swift really are doing the right thing here.
Okay, Joe, thank you. Glenn, you would like to come in there?
Yeah, I was invited after they'd set out the date of the meeting, which I didn't think was the best way to do this. We are reiterating our position on the project, but having another meeting in public on this when we've had some already and produced a lot of public information is a little bit frustrating. So I think we just need to think about how we manage this from a communications perspective. The beds review is going on, and that will deliver an answer. And when we're ready, we need to have more public engagement. But doing it before that, because the League of Friends say so, didn't feel like it would be a useful meeting to
As
entertain.
it looks as though nobody but the medical centre are actually going to show up, I'm thinking about withdrawing because I'm a governor as well as being a local politician. I don't, from what you're now saying, it sounds as though I'll have to find something else to do that evening. God, Brian will go nuts. I might phone him and record it and then keep it as a something to play to you all.
I think that would be sensible, Joe. I don't know what your view is, Glenn. Yes, we agree with you. Yes.
Okay, I won't go and be savaged in public. Never mind. I could have.
You get savaged in private instead. There you are.
Will you be in the stocks at Warwick Castle?
No, but I'm threatening to get some outside Elizabeth House, but don't start me on that one.
Right, moving on quickly.
Sorry, sorry, if you don't mind, I just wanted to ask a very quick question to Mike. Yeah, how much the Stour Health and Wellbeing partnership is involved? Do they attend the project board, or they just, how do they interact with the project board for the Ellen Badger project?
Members of the project board go to the Stour Health and Wellbeing partnership meetings, and Carol Nossiter from the PPG of the Medical Centre, who's a trustee of the Stour Health and Wellbeing Partnership, has been and is continuing to be a member of the project board. Because don't want to.
And I'm the deputy chairman of the Health and Wellbeing Partnership in Stour Health and Wellbeing Partnerships. So there's lots of joining up.
Yeah, loads of joining up. Yeah, thank you. Cheers.
Okay, thank you, Callie. So we'll move on with your permission and ask Michael Coker to talk to us about the end of life committee update.
Thank you. I was appointed to this some time ago, but the first meeting I attended actually was on the 6th of June, which was, there hadn't been a meeting previously since I think November 21 due to COVID problems. That meeting was mainly concerned, I think, with the national audit of end of life. And whilst this had acceptable results as far as all departments were concerned, I think the main feeling across the committee was that improvement could be obtained in most probably all areas. And the major feature was the importance of training and the encouragement of training throughout the hospital on this subject, which is, I think, something the board did in a workshop, according to what I heard recently. And I think, therefore, that is what we should be encouraging. Unfortunately, I was unable to attend the meeting on the 25th of July, as I was sitting in a bed in the hospital and didn't think it appropriate to join the meeting from that venue in case everybody heard what was going on. However, I have seen the minutes, and it is apparent from that that there's been a follow-up on previous meeting, which was to some extent reviewing the various schemes they had, rationalising them and getting a list, if you like, that was up to date and necessary. But again, the question of encouraging training throughout the hospital was necessary. I think the board is taking this up, as I understand it, and I would encourage that, because I do have some experience of end of life, having been coroner for Warwickshire, mainly after the process had been through. But it is terribly important, both for the person concerned, obviously a major person, but also families. It does need careful consideration. It does need careful attention. And the better that is, because after all, I suppose there are a fair number of people quite inevitably die in hospital or immediately prior to leaving immediately after leaving hospital, and it is a very important subject. I'm not saying that it's not being looked at. I think it is, but what we do need is to encourage it in all forms, and I would think that the board should be doing that.
Thank you, Michael. I mean, for interest, we had a very good presentation at yesterday's board about managing the quality of death, the experience of individuals and families surrounding death, and joining the whole process up with hospices and other relevant bodies. And it was really very, very assuring and reassuring, really, of what was going on. Glenn, sorry, have I just made you?
No, you said what I was about to say, actually, that the hospice at home service development with our local hospices is fantastic. But also to answer Michael's point, we're absolutely committed to ensuring that staff have training in supporting patients and families at end of life. It's really important part of delivering great care. So just to give that commitment.
Okay, Glenn,
Yes.
thank you very much. Sorry,
Could I say, when I say encouraging, I think that many people find it a difficult subject to be involved in, and I'm sure that includes members of staff. And I think, therefore, that's why I say encourage, because hopefully that can be done.
Yes, it's a hard. I mean, my experience is it's a hard topic to start with.
Yes.
Yes. And you know, I have absolute sympathy for staff in that respect. Okay, so shall we move on? And we are a series of verbal updates here. So David G, if you can talk to us about the Falls Group, that would be great. Thank you. So I don't know whether David's had one of his IT problems he was talking about earlier. Are you still with us, David?
Yeah, okay.
Yeah.
Can you hear me now?
Yes, we can. We can hear you very well.
There hasn't been a meeting for some time, and the latest August figures are not yet available, unfortunately. So not a lot to report, but I did get the July figures, which are very encouraging. The number of falls between June and July was from 59 down to 48, which obviously is significant, even though that was in the middle of COVID and the heat wave. Whether that's continuing, I don't know. I've no reason to doubt otherwise. In July, there were 2 serious falls which required surgical attention. And the only other thing, the board and non-execs visited the wards as part of the Falls Prevention Board, which was very encouraging. So happy to take any questions.
David, thank you very much indeed. Any questions? Mary, you have an observational question.
But it's a comment, really. I'm not sure that David was at the pre-meeting, in which case, did you? I mentioned that Russell wanted us to let him know if any of the meetings that we were members of weren't working, weren't being held, so that he knew what the picture was. So can you let Russell know if the Falls meetings are not being held? It's almost certainly staff pressures and staff shortage, so we're sympathetic to that. But Russell said he wanted to know.
Yeah, well, there is one due next week, so I'll know soon enough.
Okay, David. Mary, thank you very much. Thank you, David. So moving on, Ruth, would you like to talk to us about the an update on the Patients Experience Group?
Yes, I attended for the first time Patient Experience on the 18th of August. Ellie was in the chair. First thing up was noise on the wards, and it was suggested that perhaps patients were given earplugs, which seemed incredibly sensible. And these could be put into the League of Friends complimentary pack. It was great to hear that volunteering is back, and that's great. And the age for volunteers has been reduced to 16 years so that younger people can visit across the trust. And sixth form is to resume hospital visits from this month to November, which is great.
Yeah.
Recruiting volunteers, Stratford-on-Avon, new roles, minor injuries, the nickel unit Cafe Lomas and the Macmillan unit. Increased work through the Acute Trust on dementia, and this is being led across the Acute Trust by the Admiral nurses. Patient Forum is starting up again with face-to-face, which is great, and I'm sure you know, they do such a good job, and I know they're all chomping at the bit to get back doing work in the hospital. Place inspections to commence this month through to November, and I think they'll most probably be looking for volunteers to help on that. Hotel services report great results in the survey. They got 99.3%, which is terrific, on cleaning and food, and ISS have been given another 2 years contract. And they are looking at the future, and they're thinking of new ways of cleaning and of using new technology.
Boy,
sorry about that, Simon. Kathy Wagstaff thought it'd be a good idea for there to be a walk around Leamington Hospital. I think that was in relation to the place inspection. And that was about it, I think. Yeah, I think that's all I've got to say. Yeah, that concludes my brief resume of the Patient Care Committee meeting.
Ruth, thank you very much indeed. Are there any questions or observations for Ruth? Mary.
Sorry, it's me again. Does this mean now that governors can now come onto hospital site again? Because we were told that we couldn't, but if Patient Forum are coming back on site, does it mean that governors can now come back out onto clinical areas?
Oh, is that to me?
No, that was to Simon or Glenn, really.
Okay, well, should we pick Sharon's question up and then we'll come back to Glenn after?
Yeah, sorry, I'm jumping in because I was going to answer this question for you, Mary, because with volunteers who are returning back onto site, we ask everybody to complete a self-assessment, just to obviously make sure you're not at any risk. If you are going on to a clinical area, there is this risk assessment, there's a scoring system. So I'm quite happy to share this with yourselves and any other governors who want to come back on site. It is no longer a mandatory requirement that you have to have received both of your vaccinations. We did have that in place, but we've been told we can no longer do this because it's not mandatory for staff. So if there's anything you want, you feel I could assist with, I'll do my best to help you, Mary.
Well done. Sharon, thank you very much. Glenn.
Yeah, I see no reason why we can't get back to a business as usual position. I see Ellie's put her hand up as well on this. So, I mean, we're still going to continue to use Microsoft Teams for meetings, for convenience actually and productivity benefit, but I think visits, face-to-face visits, things like doing the inspections and linked to cleanliness, etc., then governors should be welcomed back into that. I'm sure Ellie's about to say the same.
I am, yes, absolutely. So we are moving back towards business as usual, and I can only apologise if we've not included the governors in the general communications around this. So volunteers are coming back in, so sixth formers, work experience as well, but also one of the key things we've done is we've reversed our visiting, so patients can now have 2 visitors at a time, and we're not putting an hour limit on that anymore. And on that
that's
basis,
good news.
Yeah, and on that basis, we're still asking them to wear a mask in the clinical areas, but on that basis, you know, really, as long as you are fit and well, there is no reason you can't come into the building.
Ellie, thank you for that. It would be good then if we could just make it clear to the governors what the rules of engagement are when they're coming in, so they're clear on what they should and shouldn't do, and that would be great. Super, thank you. So if we press on. Sorry, Mike, you came in before we move off. Yeah.
Sorry, so quickie for Glenn, actually. It's I'm on the board of Health Watch, Glenn. You may not know that. Are we likely to be able to continue enter and view from a Health Watch point of view into the trust's premises?
Yes.
Thank you very much. I'll talk to Chris Bain about it.
Good. So that was a quickie, wasn't it? That's great. So,
Had a quick answer. Thank you.
So moving on then, Sue, perhaps you give us an update on the Patient Safety Surveillance Committee.
I would, but I am going to give you my heartfelt apologies. I thought I was actually giving it to the patient care, feeding back to the patient care committee, and it's sitting on my desk at home. I do apologise. Can I send something through to you for the minutes? Or I do apologise.
So that's fine. Yes, please. If you can send something for the minutes, then that would be lovely. Okay, thank you. So in that case, moving on, Pat, will you give us an update on the patient portal group, please?
Right, okay. Roger Lloyd confirmed with me that the patient portal panel had not met since January, and as I needed to report to this Council of Governors, Roger arranged a Teams meeting. This was held on the 30th of August and was attended by Devon Bradley, Darren Sargent, Emma Waldansky from the project team, Roger and myself as governors. There have been a few organisational changes in the project team. To date, 52,179 patients have registered with the portal. 76,705 patients have been invited. 68.9% is the average portal adoption rate. 72.1% of registered patients have chosen to go paper-free. Gynecology at 80.2% has the highest adoption rate as a department. In the last 6 months, clinical letters and discharge summaries became available on the portal. So upcoming, the NHS Wayfinder initiative, linking data from different organisations' patient portals to the NHS app, which will provide patients with more information they need about hospital appointments all in one place. Phase 1 will be in autumn 2022 and phase 2 has yet to be confirmed. By this autumn, patients should be able to sign into the patient portal using NHS app credentials. I was assured by Devon Bradley, Business Support Manager, that satisfactory progress is being made and the team are working on the roadmap for the next 3 years. The next meeting of the forum is 5th of October 2022.
Pat, thank you very much indeed. That's very fulsome. Any questions or observations for Pat? Okay, thank you very much. So, Jean, perhaps you give us an update on the Safer Discharge Group, please. Oh, sorry. Before we move, so we have a question. Sorry, Jean, to cut you. David, you had a question.
Yes, sorry, I finally got it to work. The portal is all very well, but it's not suitable for people like myself that don't have a smartphone, which is a large number of elderly people. Not that I'm elderly, but financial providers and so on now are increasingly using the internet instead. For messages, they're using the BT messaging facility, but it seems we just will not consider alternatives.
Glenn, you put your hand up very quickly.
Yeah, well, hopefully Roger's not going to contradict me on this, but I thought we had confirmed that you can access this through a PC, through a laptop, through other devices other than just smartphones. But that was what I was reassured on last time the question was asked, David. But if that's there you go. There's the answer from the Stratford jury. So I will go back and check that. Roger, did you have anything to say on that?
I was going to say, so far as I was concerned, we'd already raised David's concerns with Devon and the Zesty team, and they were saying that you can do it. So hotfoot from you, if you Glenn have a go at that through from your side. Pat and I will make sure that that it gets into the system, because I agree with David, smartphones aren't everywhere, but we need PC access as well.
I will respond directly to David on it as soon as we can.
Okay, it's a perfectly sensible point, isn't it? So, Michael Cope.
As somebody who is elderly and doesn't have a smartphone, can I support David?
Okay, thank you. I think he doesn't need supporting. I think Glenn is totally on board with the principle. So, okay, I think David, yours is still a legacy hand, isn't it now? So
Yes, sorry.
no, it's no problem. So in that case, let's move on and back to Jean, if you're still there, Jean, and an update on Safer Discharge Group, if you would.
Yes, we didn't have a meeting last month, so it remains to have the next meeting to discuss things. But I've already referred to the changes and improvements in terms of the TTOs, which is one of the main areas that they were focusing on. So I can provide assurance that they know where there are areas of concern or areas where we're doing really well, and they make sure that they put in proper systems to measure it and see if improvements can help.
Jean, thank you very much. Questions or observations before we move on? Okay, thank you, Jean. That's lovely. So, Roger, an update, please, on the Wayfinder Group.
Thank you. So far as the Wayfinder project, the meeting that was scheduled for late July was cancelled for operational reasons, as most of the invitees were operational staff and up to their ears in ordinary business. There is a meeting scheduled for next week. So we've got out of sequence slightly. Unfortunately, I can't make that meeting, and one of the other governors volunteered to be my deputy. Unfortunately, we can't find who. So whoever it was, please contact me so we can get that sorted and details passed through to the organizer.
Thank you. I think it might be Ruth. She just put a hand up. Ruth?
Yes. Sorry, Roger, it's me. And,
right. Excellent.
And I contacted the boss chap, can't remember his name now, to say that unfortunately your meetings clash with the patient experience. So I can't be in two places.
Right. So offline, I will get in touch with you and with Laura Evans, who is the administrator working this group. So I'll make sure you're in the loop.
Super, Roger. Thank you.
Yeah, I apologise.
No, not an issue.
Will that clash of meetings, is that a regular clash of meetings? Or was it just a one-off?
No, I think it's a regular clash, actually.
Because
you're out of sync now, aren't you?
Yeah, the next meeting is not in sync as before. So after this one, for something else, we've shifted it out to shifted the framework. So we'll be in touch.
Okay.
If it's not resolved, then unfortunately we'll have to find someone else, Ruth. But let's hope it can be resolved so that you can do it.
Indeed.
Okay. Cool.
Thank you.
Right. Thank you, Mary. Thank you, everybody. And then the final verbal update is, in fact, from me, which relates to the Business Oversight Committee. So after the change in the way F&P worked, that created some challenges around business oversight. Now, Russell and I have had quite a long conversation about how we can try and replicate that and keep you all informed in the same way that business oversight was. We've already introduced the governor's catch-up meeting, which is typically after on the same day as F&P meeting at about 4 o'clock in the afternoon. And our intention is to try and get that into a more formalised structure so that all governors can receive the reports. Russell will do his normal report. I will do an F&P related report to you at that meeting, and Richard Colley will do an audit committee report to you at that meeting. So it's slightly more formal than it is, but it gives you the detail you were getting at this oversight. And if there's any other big issues that other NEDs are across, like the elective hub we've spoken about, then there'll be opportunities for those non-execs to talk about those issues at the meeting as well. So I hope that makes sense to you all, and that we can try that for size over the next few months, and hopefully that will be an adequate replacement for business oversight, but it can certainly evolve if we need to make any changes to it. So 2 questions straight away, Mary. I think, Mary, you were the first with your hand.
Is there any possibility of the when we have those meetings of us having sight of the agenda for the F&P meeting, just the titled agenda, not minutes or anything, just so that we can see what sort of subjects are being discussed and then ask questions if appropriate? Because if we don't know what's being discussed, it's difficult for us to know what to ask.
No, I understand totally. Typically, the agendas, Mary, are telling you which discipline is talking about their subject. I don't think there's any more detail on the agenda typically than that, is there, Glenn, that we could share with the governors, or am I incorrect? Yeah. Then it's not.
Just knowing which team or which area is being involved would, for our assurance, would mean that we know that area is being discussed.
Well, that's what I'll do. I'll make sure that you see the agenda, you know who is talking in the next F&P meeting, so you can see the agenda. But I don't think you'll find it any more informative than all divisions are out to play really in F&P, and each one then is in effect a separate meeting where they are under scrutiny and have their feet held to the fire, and that's what we'll report again.
Okay.
Okay, thank you very much. So that concludes the reports from representatives on projects and groups, and we move into the next area, which is governance matters. So if we're happy to keep the pace going, Mary, perhaps you'll, Sarah, perhaps you'll talk to us about the update to the trust constitution.
Thanks, Simon. And so we convened a constitution working group to review the trust constitution to ensure it reflects the current practices and processes in place. The proposed amendments are shown as track changes, which have also been reviewed by the trust solicitors to ensure we're legally compliant. A further review will be required once the model constitution has been updated to reflect the Health and Care Act 22. The proposed amendments were considered and approved by board yesterday, so submitted today to the Council of Governors for approval and ratification. Thank you.
Mary, I'll call you Mary twice now. Sarah, thank you very much. Are there any questions or observations for Sarah? I don't expect so. Okay, excellent, Sarah. Thank you very much indeed. So it is Mary this time. Mary, can you talk to us about the General Purposes Committee?
Yes, of course. Well, I take it that minutes are read, and just to draw a couple of issues out. We set the agenda of the Council of Governors as usual with insurance issues, but I'm aware that it's only the General Purposes Committee governors that raise the issues of assurance. So if there are any governors who aren't on the General Purposes Committee, have got anything that they would like discussed or raised in the assurance issues, or ask Glenn to put into his report, then do let us know. We're not excluding other governors from that. We've now, as you know, established a regular training programme that will be a standing item on General Purposes. We've drawn up a list of topics that submitted by governors, and there'll be, as you know now, pre-COG training sessions, and then an additional session, at least one additional session between the Council of Governors meetings. There was a huge long list submitted, so there will have to be quite a number of sessions, I think. There was a long discussion about engagement, and I thank governors who sent in their ideas of how we could improve engagement and increase membership, which have now been forwarded to Mary Powell. The vacancies on the committees were discussed and have been agreed, and just for clarity, the Patient Safety Committee, representatives Sue and Deputy Pat. Patient Experience Committee is Ruth and Deputy Sharon, and the Deputy to Mike on the End of Life group is John Egan. And so there was a bit of confusion about that, but that's now resolved. And just for the records, I now attend the Medicine Safety Committee and will be reporting back to the Patient Care Committee from there. But I'm happy to take any questions.
Super, thank you very much, Mary. Hang on, see who that is. Mike Blacksman.
Sorry to stick my nose in again. It's on engagement, really. I'm quite concerned that we're going to end up with a multiplicity of engagement strategies, because Swift are working on one and they're probably more advanced than most. The other two major providers for services in Warwickshire, I think, are both working on their new engagement strategies with patients. The ICS is writing an engagement strategy with patients as well. And we could end up with 5. And I'm hoping somewhere there might be some coordination, which mean that engagement with patients on healthcare and health services actually has a common thread. Any thoughts?
Okay. Over engagement, Mary.
I understood that this was actually much more of a joint engagement strategy with our partners. I don't know whether Glenn knows any more, but I thought that Mary was engaging with the local authority and other people. She had quite a large church of people at the workshops.
Okay. Yeah, the ICS is developing their own, but UHCW wrote one that failed in about 2021 and hasn't been renewed. And as far as I know, CWPT don't have an engagement strategy.
Okay, all right. So Glenn, you came up to try and make an observation.
I could only agree with the sentiment of the question, actually. So, I mean, firstly, from an ICS perspective, what we should be trying to do is to bring that knowledge together into one place rather than duplicate. So in all conversations I'm having with the ICS, it's about how we share things rather than duplication. So I'll pick that up, Mike, with them. I mean, we've certainly seen the benefit in our own direct engagement with communities, but we do need to just make sure that's available to everyone rather than something we hide from everyone and then ask them to do something else themselves.
Yes, we don't want engagement fatigue in this process, do we, really? But Mike, thank you for raising that.
Thank you.
You had your hand up.
Yes, thank you. I raised it in the past and I didn't make it. I don't know if I'll try and make it to the next General Purposes Committee, Mary. There is a list of training topics that will be covered by the training. I raised something about productivity and in the past, and there was the trust report to NHS England on productivity. There's loads of different measures that they use, but I just wanted, I don't know, there is a topic, NHS finances, but I don't know what would that cover, because we had training on NHS finance in the past. It's good to have a refresher, but it would be good to sort of have something on productivity, cost and productivity, especially in respect of the measures that NHS England uses to look at how trusts perform. I don't know who can, if that could be included, and who can. I know sometimes Kim goes into detail on that, and not on this occasion, but I would like to understand more on this subject. So
okay,
that's all I wanted to say. Thank you. That's all.
Okay, thank you for raising that. Mary, you put your hand up in response.
Can I just come back on that? The NHS finances was put onto the training agenda very much aimed at the new governors. There were new governors or governors who very much don't have an NHS background. So it may be that governors who've been around a long time or had the training in the past wouldn't need to attend, but it was aimed at the new governors. A specific request, and maybe some form of productivity can be pulled into that.
Okay, so your question was more particularly about productivity, Callie, I think. Than...
Yes, if that can be covered as training, because there is a lot into that subject, and it's not easy for people to understand unless if they get training, and that's it.
Okay, totally understand. Glenn, you were going to comment on
I'm sure that will be in the scope of what Kim would talk about, because I'm sure she would talk about reference cost and model hospital, that kind of thing. Well, which also will feature in our monthly board updates as well. So I'm sure that will be in scope.
Okay, Glenn.
That's what I was assuming. Yes.
Super. Okay, Glenn. Callie, thank you for raising the point, and thanks for everybody's comment. So that moves us on, I think, then to Jean with the draft minutes of the Patient Care Committee.
Yes, can I just confirm they're no longer draft? It was just the intercommunication. And Sarah didn't like to say they were agreed yet. So I'll take it as read if anybody's got any questions, and terms of reference will be referred to in the next but one item. So any questions, really, I think.
Okay, Jean, thank you very much. Mary, you're on mute, Mary.
It was for clarity and confirmation, really. My name appears against several items on the agenda. I wasn't at the meeting, and I was very surprised to find his name. It shows me right from being there. I'm not quite sure, because one of the items, well, I've agreed with Jean that to leave the minutes as they are, because that's how the meeting must have gone, if that's how it was minuted, and that I'll clarify at the next meeting what the actual situation with those items is. But it's raised an issue for me about the implementation of patient-initiated follow-ups, which is something that I was asked to find out about, but I don't know why. But perhaps that's something we could discuss at some stage. Whether that's something that Glenn's got an update on now, or whether we can do that outside this meeting.
Glenn?
Yeah, it's quite a big subject, but it's a good one for us to talk to you all about and get your views on. Part of the National Elective Care strategy is to move to patient-initiated follow-ups and not just automatically follow up every patient unnecessarily, because some patients are perfectly able to manage their own conditions. Some need more support. There's something called Super September, which we're in the middle of now, which is looking at some of these initiatives nationally, and we're doing some work on that locally to improve our patient-initiated follow-up numbers. So maybe a bit of a focus on outpatient improvement would be a good thing to bring to Council of Governors at some point in the future.
Okay, yeah, good idea. Thank you, Glenn.
Thank you.
And Ruth, you had your hand up, I think, a moment ago.
Well, that was a question I actually put forward for the round table to be discussed. It was about communication.
Oh, okay, good. So that's very opposite in that case. So, okay.
And just to say, the reason Mary was given that item to speak to was because she's our pharmacist expert governor. But before allowing the minutes to go out, I did make sure that she was happy.
Okay, Jean, thank you very much. So before we press on, Sarah, I think we, just for clarity, we have a session planned for Sharon Ellswood to do a presentation to the rest of the governors in October, I think, around her subject.
Yeah, I think it's more going to be November actually, Simon, but yeah.
Super. So
and this annual report's been submitted for information today.
Super. Thank you very much. So we look forward to that, Sharon, when it comes around in November.
Thank
in
you.
between times, I think we have you down here, Jean, again, I think for just the volunteer services annual report. Is that correct?
I don't think it is.
No, it should be you.
It's for Sharon. She
me,
was
yeah.
going to speak on at the patient care committee, but A, it's been reduced to 1 hour, and B, and we didn't think that gave her a fair crack of the whip.
No,
and B, we thought it was right that all the governors should hear about the fantastic work that they do.
And we do too. I think we're just conscious that we have a very tight schedule here today, and we don't want to curtail what you have to say, Sharon, because it's very important. And we'd rather you had a session on your own where you can give, full force to what you're doing, and all the governors can listen and pay attention to that.
Yeah,
so
thank
if
you.
you're very happy with that, I think that's what we would like to do and prefer to do.
Yeah, because I can talk about volunteering until the cows come home, so that'd be good.
Well, we'll give you enough time to talk about it until the cows come home in that case. That'd be great. So
thank you.
Okay, so in that case, we should move on and talk about Sarah, the terms of reference for the patient care committee, if you don't mind. Thank you very much.
Thank you. So the patient care committee have reviewed their terms of reference because the committee has recently changed to a non-exec director-led meeting for the foreseeable future due to the operational pressure on the chief officers. So the proposed amendments are shown as track changes for the Council of Governors consideration and ratification. Thank you.
Thank you. So this is for approval, Sarah, just for clarity, or just for information?
Yeah, it's for ratification.
Okay.
Thank
so,
you.
Jean, you put your hand up, I think, straight away.
Just to say that in the minutes we said we would review it in 6 months just to make sure that it met our needs.
Okay, understood. So with that,
can I also just say, so it's minuted, a huge big thank you to Dr. Spraggart. He actually answers to all the clinical stuff because of the background situation that's ongoing. And he's been such an amazing support and really willing, which is amazing considering he's also got his clinical job, his day job.
Thank you, Jean. I'll make sure he knows what you said. Sarah, you put your hand up straight away again.
Yeah, just to point out that the next date of review is actually already noted as January 23.
Okay, which is your sixth point. So please raise your hand if you don't agree with this proposal, which I think has already been through you. Otherwise, we will ratify it now. Excellent. Thank you all very much. So we'll move on. And we are now into, I think we are still, I've got a window just come up behind what I'm trying to read here. So I think we're still with you, Sarah, on the report on resignation and appointment of governors. Thank you very much.
Thank you. So I'll take the paper as read, but I'd just like to add that following the recent election process, we do have 2 new governors. So Mike Flaxman, which we've obviously all met earlier today, is our new public governor for West Stratford and Borders.
Welcome, Mike.
Roger Weddle, he's our new staff governor for clinical support, and as explained earlier in the meeting, he's been unable to attend today. We do still have a vacancy for the staff governor for medical and dental. We are going to be taking this to management board to see if we can get some options of how to engage some of our consultants to get some interest in that post before we go out to election again.
Okay.
So happy to take the paper as read and then answer any questions. Thank you.
Sarah, thank you very much. So are there any questions or observations for Sarah? No, super. Thank you, Sarah. Thank you very much indeed. So that moves us on to, I think you again, Sarah, then, Register of Governors. Oh, no, sorry, I beg your pardon. It moves us on to Mo. Good afternoon, Mo.
It is not, Simon is not actually joined us. Sarah has tried contacting him to see if he could join us earlier because we're running slightly ahead. Here he comes.
Here he comes. There you are. That's what you call timing, isn't it? So Mo, are you there? That sounds like a Eurovision Song Contest now, doesn't it? So, I don't know whether you do have Mo yet or not. Is he in, Sarah? Or...
Yeah, I did admit him.
Good afternoon. Good afternoon, Simon.
Hello, Mo. That's called timing, isn't it? I think so. Over to you then for your report, and thank you very much for coming and giving it.
No, fantastic, and really pleased to be joining. And apologies if I'm a few minutes out of sync.
No, we're running ahead of schedule for a change, so you're fine. It's a good job you're early.
Okay, fantastic. So I'm hoping, Sarah, the overall document, the auditor's annual report that we issued based on our work for the trust for the year has been circulated. As part of papers.
Yes.
Yes, it has. So there's a paper here up on the screen here, Mo.
Okay, fantastic. So you'll all be pleased to know that I won't be going through that page by page at all. So we'll take that as read, and so really pleased I think to be back with you again, because I probably attended Council of Governors with you probably at the golf course a few years ago in person. So the auditor's annual report that we've issued for the year ended 31st of March 2022 sets out the work that we've undertaken as your external auditors, and just sort of referring to the key messages within that paper. So firstly, we've undertaken our audit of the Trust's financial statements, reviewed the annual report and the annual governance statement, and undertaken the reporting that we're required to nationally for the Trust as external auditors, and really pleased to be able to report that we issued an unmodified opinion. So that's a clean opinion on the Trust financial statements for the year. We've also completed the work that we're required to undertake in terms of the arrangements that the Trust has to secure value for money. And this work is based across 3 areas. So it covers financial sustainability, it covers governance, and also economy, efficiency and effectiveness. So quite sort of broad ranging, and we're required to consider the arrangements at the Trust with a view to identify any significant weaknesses in arrangements that may exist. Again, really pleased to say that we were able to conclude positively that there were no significant weaknesses identified as part of our work. In respect of financial sustainability, we do have a note that similar to other organisations across the NHS and certainly across the local system, it is quite a challenging landscape going into the current financial year 22-23, and that there is always a system deficit being managed, whilst the Trust was indicating a break-even position. And I know following subsequent revisions and national funding support to cover some of the inflationary pressures that exist nationally, the Trust and the system were able to pull together and for approval a plan that was break even at system and a smaller surplus for the Trust. So yeah, there was a plan there to manage the financial pressures being faced by the Trust. And we didn't highlight any sort of concerns or recommendations across the other areas, whilst we did include in the commentary some points for noting for the Trust as they move forward in terms of value for money as well. That's all I was going to cover in terms of the brief presentation, but certainly happy to pick up on any questions that anybody has.
Mo, thank you very much. So are there any questions for Mo? Okay, Mo. Oh no, here we are. Sally,
sorry. I don't know if I'm asking the right person this question, but obviously we're talking about value for money and all that. But what about the energy crisis and costs that have to do with whatever, electricity and gas and all that? Does that affect, and how much it affects the Trust's finances? That's all. I'm sure it has to do with the whole of the NHS, but I'm just asking the question, that's all, because it affects domestic and other businesses anyway.
It does. Yeah,
domestic users and others. Yeah.
Yes. Well, Liz Truss has been talking about that today, as we all know. But I think that isn't a Mo question, I'm afraid. I think it's more of a Glenn question. So, Glenn, if you just like to answer that, that's great.
Yeah, I was just going to say that, but I won't expect Mo to answer that on our behalf. And I mean, Kim was here earlier as our Chief Finance Officer. That would have been a good question for Kim. But just to at this stage, we actually entered into a contract that protected our energy prices until later on this year. So at the moment, other than the other impacts of inflation, which are quite high, that particular one has got a degree of protection, and we wait to see what the national response is going to be moving forward.
Okay, but thank you for your question, Callie. That's great. Any more questions for Mo? Mo, thank you very much for coming in, and thank you for being early, and we'll see you next year probably.
No, it was a pleasure. Thank you, everybody. Have a good afternoon.
Okay, super. Thank you very much. So that then moves us on to Sarah again, and the Register of Governors and Governors' Interest, the annual review. Sarah?
Thanks, Simon. So these are for information before they're published on the website, but I'd just like to highlight a couple of amendments that I'll be making before they are published. So Pat Scott has informed me that her grandson is a physiotherapist at the Trust, so that will be declared as an interest. Roger Weddell will be added and he has no interest to declare. And Mike Flaxman has informed me that he's chair of Binton Parish Council and a non-executive director for Health Watch Warwickshire. So with the inclusion of those onto the register then, and therefore receiving a note in. Thank you.
Sarah, thank you very much. Okay, so moving on to Roger. Proposed changes, Roger, to non-executive director voting rights, which went through the board yesterday and is now with you.
Thank you. This is merely effectively recording the position that as it stands at the moment, there isn't anything in the Constitution that covers voting rights. As the council appoints the non-executive directors, it's felt appropriate that the council should approve the changes to voting rights. This is reflecting on this particular occasion that Rosemary Hyde is coming towards the end of her term as a non-executive director, and therefore is stepping back from chairing the audit committee, with Richard Colley taking up that role. So it's more appropriate that Richard has the voting rights in place of Rosemary. And I would ask the council to agree the recommendation from Nominations and Remuneration Committee that we change these voting rights.
Roger, thank you very much for that. Just for clarity, Sarah, this is do we require to ratify this as a group? We do. So
that's right.
We do. Super. Thank you. So I assume we don't have a problem here, but if anybody has a problem, please can they raise their hand? Okay, that's lovely. Thank you very much.
Thank you.
And Richard, good luck with the audit committee. And I don't
Thank
mean
you.
there's not an edge to that. I just mean good luck with the audit committee. And so moving on, again, Roger, with the appointment of nominated non-executive director, Pranjit.
Yes, the report here, if I scroll through to it on my screen, the report is self-explanatory. I'll take it as read and will answer any questions that anyone may wish to raise.
Okay, any questions from anybody? I don't expect. That's lovely. So again, just to make sure, this is, if anybody, I don't think we are. Are we asking for a ratification here, Sarah and Mary, again? I think we are.
Yeah.
So
Yes.
We are. So if anybody has any objection to Pranjit, he is here now, so it'd be a bit of a problem. But if anybody has an objection to Pranjit, please can they raise their hand? That's lovely. Thank you, Roger, very much.
And it's important to note that this is in effect retrospective in this particular case, because we should have picked it up beforehand.
Indeed we should. So thank you. It is indeed retrospective. So is there any other business from anybody in the meeting? Okay, thank you very much. So that moves us on to questions from governors. So I'm not aware of any questions, but are there any questions from governors that they'd like to table at this moment? Super, thank you very much. And I don't know whether we have any members of the public here, but we don't. Sarah's shaking her head. So in that case, we won't have any questions from members of the public. So that gives us an opportunity then to adjourn the public meeting and move to the confidential meeting. So do we all want a 5-minute stretch and walk around? Jean's applauding. There you are, my first good decision of the meeting. So should we get back together at 4 o'clock then?
Yeah, just a note to everyone, Simon, it's a different link for the confidential meeting.